Hello and welcome back. Today's webinar is about optimizing operations so that we can boost productivity in the face of Medicare cuts. Practices are increasingly faced with the challenge of growing demand for healthcare services, increased overhead, and decreased reimbursement. Greater efficiency must be a major priority. Efficiency is the relationship between resources utilized and outcomes, such as patient wait times or final health outcomes. Many studies have compared healthcare expenditures to patient outcomes, and from these study results, some improvements have been made to address clinical inefficiency. Healthcare industry expenditures still outweigh overall positive patient outcomes. So, where does the disconnect come from? The answer is easy to find. Medical practices give too little attention to the other side of the practice, the office itself. Here's what we're going to be talking about today. We're going to first begin by talking about some productivity statistics because we have to know where we are now so that we know when we get where we want to go that we had progress. Then we're going to talk about the three concepts of efficiency, how to measure productivity, symptoms of poor productivity. I'm going to share the results of a poll I recently did about what part of the practice administrators think is their weakest part. We'll talk about what can you do today to make a change. Then we'll talk about 5 key benchmarks, key outcomes to look for, and then we'll go over a couple of case studies. An October 2023 MGMA statistic poll found that 19% of practices surveyed were exceeding their productivity expectations. 48% said that they were on target, and 1/3 reported that they were below expected productivity levels. So there's a lot of opportunity for more efficiency in most practices. Now let's dive into 3 key ideas about efficiency: technical, productive, and allocative. First up, technical efficiency. This is all about how we use our resources, like capital and labor, to get the best health outcomes. Basically, it's about squeezing the most improvement out of what we have. But technical efficiency alone does not help us compare different interventions. For instance, if one method gets the same or better health results but uses a different mix of resources, technical efficiency doesn't tell us which is better. All right, now let's chat about productive efficiency in healthcare. This basically means getting the most bang for your buck when it comes to using resources to improve health. It's about figuring out the best mix of things like staff, equipment, and treatments to achieve the greatest health benefits without spending more money than necessary. Imagine you've got a set budget for healthcare. So you're the patient and you have a certain budget for your healthcare. Productive efficiency is all about using that budget in the smartest way possible to get the best results for oneself. It's like finding the perfect recipe where you use just the right amount of ingredients to make a really great dish, but you're not have any waste at all. So productive efficiency is all about making sure every dollar in resource is working hard as it can to help improve people's health. Now on to allocative efficiency. This is where we look at the bigger picture. It's not just about how well we use resources to produce health outcomes. It's also about how well we distribute these outcomes across the community. In summary, technical efficiency focuses on what we have in the best possible way. Productive efficiency is about picking the best combination of resources for the most benefit. And allocative efficiency is about balancing healthcare programs to boost overall health. All right, let's break down traditional productivity measuring methods in healthcare and how they focus on numbers rather than patient care. Typically, we look at productivity through hard metrics like time and financials. This means we're focusing on how quickly services are delivered and how much they cost. In other words, traditional methods are all about human labor and cutting costs rather than the actual quality of care that was provided. Time metrics are pretty straightforward. How long does it take to take care of a patient and complete their services? The number of patients a doctor sees each day. How much time healthcare workers spend with each patient. Financial metrics, however, look at labor costs. This includes wages for staff and whether other resources are being used efficiently. Sometimes it means redistributing salaries, trimming the team, or hiring temporary staff. Overtime can be crucial for emergencies, but it can also be excessive when it's just for extra paperwork or extended patient time. Supply and equipment costs. This involves weighing the cost of high-tech devices against their benefits. We have a lot of high-tech devices we have to use in our offices, and they're not cheap. So sometimes you might want to opt for cheaper equipment to save money, but it's important to ensure you still have enough supplies and equipment to meet patient needs. Then we have our other expenses like utility bills, like electricity, heating, and water. They're essential, but finding ways to reduce these costs can also produce financial productivity. Traditional methods mainly focus on these quantitative metrics: how many patients are seen and how much money is spent. This approach often means clinics might cut back on hours, hire only essential staff, or rush through patient appointments to save time and money. However, there's a catch. By focusing solely on these numbers, we might miss out on the quality of care. Patient satisfaction is crucial and cannot be measured by time and cost alone. If patients aren't happy with their care, then the productivity improvements in terms of numbers might not actually reflect a successful outcome. So while traditional methods are useful for understanding efficiency, they don't give the full picture of how well patients are being cared for. Now let's talk about some common symptoms of poor productivity. A study from the American Academy of Family Physicians found that poor management of your team can lead to a lot of inefficiencies. Think about it. Uneven workloads, struggles when someone's out on leave, and just not good communication between staff can really slow things down. Take the front desk, for example. It's a busy place with tons of tasks involved in checking in and out patients. If the check-in process isn't smooth, or if there's confusion about who's doing what, it can lead to other important duties like answering calls, being neglected, and we all know that means long wait times, missed return calls, and a lot of frustrated patients. This kind of poor call management doesn't just hurt patient satisfaction. It also messes with your staff's productivity. This same study says that having the right number of staff with clearly defined roles is key to running an efficient office. Inefficiencies like these impact both your staff's productivity and your clinic's finances, which can ultimately lead to a drop in the quality of patient care. At the core of these issues is often mismanagement of resources. Since the real strength in healthcare is the people providing the care, it's crucial to manage this resource effectively. This is the poll I recently conducted on the ASOA iMail listserv. The biggest category that people said was most unproductive part of their practice was onboarding new staff training. One respondent said that it took him something like 120 to 260 days to onboard new staff. And boy, oh boy, that's a huge expense, isn't it? There were quite a few people that commented on this one thing. Then at 15% each, we have one or more of the physician's clinics. So maybe they have a physician who's not productive enough, or takes a long time with patients, or has a lot of rechecks, or who knows. And then we also have the other 15% is clinical operations. One respondent said they had a very disorganized tech staff, that they were always in each other's ways. And when I questioned her about how many techs they had and how many exam rooms they had, it sounded to me, just from my distant perspective, that they were overstaffed in the tech department. And she said it's just very confusing, disorganized. Everybody's in another person's way. So, could be something as simple as being overstaffed. Then another 15% was clinical operations. And so one of the things that was mentioned was doctors who won't standardize workups and testing protocols. This creates a lot of confusion, and then techs have to leave their room to go ask the doctors a question about a given patient. What should I do? Do you want this test? Do you want that test? Do you want, me to dilate them or whatever? So these are kind of easy things to fix. One thing I suggest is making a spreadsheet of all your doctors and then each of their exam types and then the components that they want done or the testing they want done for each different exam type. And you can put this on a shared drive and then put shortcuts to all your desktops. You can use color codes to make it easier to digest. And that way your techs have no excuse for not doing the components the doctors want and need. They can just minimize or move aside their EMR, and there is a shortcut to their protocols. And then when the doctors change their mind, which if they're like the doctors I worked for, they always change their minds, then you only have to update it on your main server location or, wherever that home file is. And it'll auto-populate out to all your desktops. All right, so who is iTech training and what do we do? We train techs and we develop administrators. We put on these webinars because our clients are telling us that these are problematic issues for them. And we want to be the ultimate resource for ophthalmic administrators. We have heard over and over again that they have to increase productivity because of Medicare cuts and stay, above those Medicare cuts. So that's why we're conducting this one in particular. And I hope it's helpful to you. Let's talk about how our practice evaluations can maximize productivity in every area of your office. Some of the things we do is we evaluate appointment templates. Not my favorite thing to do, but I'm very good at doing it. Use of space. We had one client who had an OCT on one end of the clinic and all their tech rooms were on the other end of the clinic. Sometimes you need to find some more space because you outgrown your office, but you're not ready to build out. And so you have to find a better, more creative use of space. We're very good at that. Placement of equipment for efficiency, throughput, clinical and administrative efficiencies. And also we provide you with a comprehensive report outlining our observations and the actionable steps that need taken to get the most out of your team, doctors, and facilities. So what can you do today? I'm going to send you a link to an article that John Pinto wrote, which is super awesome. I'm going to email that out to you all after today's webinar. And start by assessing current roles and setting clear boundaries between responsibilities. Let technicians take on more active roles in patient care so physicians can focus on what they do best. Building a care team with other clinicians like PAs can also help more patients get the attention they need. Measure your practice's productivity against industry benchmarks. John Pinto is a great resource for industry benchmarks. Conduct a time flow study. This can be time consuming, but it is a service we offer, and you can gain amazing insights into your physician and your lay staff's productivity by doing one. Do efficiency and skills evals on your staff. You'd be surprised to see what we see when we go into practices and do this service for our clients. Sometimes we see things which can be easily modified to improve productivity, but you won't know the issues unless you do staff evaluations and efficiency assessments. Assess your labor levels and costs, and you can do this by first assessing productivity, as we just talked about, and then looking at benchmarks. Being markedly overstaffed is just as bad as being understaffed. Think about using technology to automate things like delegation and scheduling. This can take some of the load off of practice admins, and it's definitely worth checking in with your EHR provider to see what tools they offer to help streamline a lot of your processes. Now we're going to talk about 5 key benchmarks. And the link to the article where I got this from is at the bottom here if you want to take a deeper dive into it. So how to calculate your overhead ratio is you divide total operating expenses by total practice revenue. You exclude the operating expenses exclude from the operating expenses the salary and personal expenses for any revenue generating provider, including MDs, ODs, and physician extenders like PAs. What's healthy is 50 to 70%. A healthy overhead ratio for a retina practice is likely to be about 5 to 10% lower than it is for a comprehensive practice. And I got some great information from Derek Priest. A lot of this information came from some articles he wrote, so shout out to you, Derek Priest. This gap can close as retina specialists get hit with injection reimbursement decreases. Review your staff needs and adjust staff size. Assess staff compensation. You can also look at your retirement plan for potential tax savings. Identify ways to optimize your patient encounters and consider outsourcing billing and collections to a professional, revenue-focused vendor. Not just any old vendor, a revenue-focused one. Provider productivity benchmarks for cornea and pediatrics are around 800 to 1.3 million a year, and slightly less for retina, maybe 1 million to 1.8 mil. You want to identify any areas of decreased productivity and make a plan for improvement. Collections per full-time equivalent staff member, a healthy ratio is about 20 to 26%. And how you calculate is you divide total collections by the number of full-time equivalent staff members in that department. And I'm talking about the collections department. And what is healthy is, or billing, I should say, what's healthy is 140,000 to 200,000 per full-time equivalent. And as far as your ratio of full-time equivalents per provider, you should see about 4 to 8 staffers per provider. And that can vary depending on how many scribes you use. Some doctors use 2 scribes, some doctors use 1, some use none. So that can vary a little bit. Now let's talk about outcomes, because that's the good stuff. Boosting productivity in your office can be super impactful, and here's how. A better patient experience results in quicker transactions and a smoother processing. That means less hassle and happier patients. When care is timely and accurate, patients get better results and fewer delays. This can result in better health outcomes. A streamlined workflow helps everyone work more efficiently. So use smarter resources for developing streamlined workflows. That's a huge thing to look at. Fixing workflow issues can make clinicians feel more satisfied and improve the return on investment. And we all have heard in the last 4 years about people being burned out, and it's a thing, but a lot of staff leave practices for that very reason. So if you can fix your workflow issues, it can give you a happier staff and lower turnover, because productivity improvements can help your staff stay around longer because they're less burned out. A more productive environment contributes to a positive overall culture in your practice. Good productivity programs boost your reputation and quality, which can attract more patients. Keeping productivity in check helps manage service demands and can make care more affordable for patients. Now let's look at a couple of case studies. These were 2 practices that we've worked with, and those are not the actual photos of these practices. They're just stock photos, but good-looking men. So talking about these case studies, one of them was a multi-location 18-doc practice. The practice had noticed that their costs were increasing as income was weakening, and their clinic always ran behind. So they did an analysis, and they found that they had Medicare cuts and they weren't maximizing MIPS opportunities. Plus, their appointment templates needed reworked. They hired 2 full-time employees who were solely responsible for MIPS compliance and reporting. This resulted in over $800,000 of MIPS money. They also did a comprehensive time flow analysis and reworked their template and staffing levels accordingly. The other one was a 6-doctor practice, and this practice was overstaffed. They also had equipment on one side of the clinic, and the techs were all on the other side of the clinic, and it was a long walk between them. They also only had 1 OCT in their highest volume clinic, and they always were backlogged on their OCTs. The doctors didn't use scribes, and one of their doctors was a talker. This really made his clinic run behind. The practice tightened up staffing by using some creative ways, such as offering flex hours to some people who didn't really want full-time work. This is a great way to keep your staff satisfied while also tightening up your staffing. They often used equipment closer to the tech area, and they bought a second OCT. They trained techs whose responsibilities included both scribing and keeping docs, even the talker, on time. Now, this can be a delicate thing to manage when you have a doctor who's having excessive social chatter and he or she has patients waiting. I worked for a doctor like that, actually a couple of them. And one strategy I have found that works really well, and it's very discreet, and the patients have no idea that you're signaling to the doctor they need to move on. And that is, you talk to the doctor that's a talker and you explain to them how this is impacting their clinic and clinic flow and technician, workups and this and that, and help them understand that. And also we want to say, yes, we do want to connect with our patients socially, but not to the degree where it's going to keep another patient waiting longer because of it. So this is what we did in my clinic, and this really worked. So we had a scribe. So this one doctor had a scribe in with him all the time, and then another scribe waiting to scribe in the next room. So that scribe that was waiting in the next room was kind of keeping track of how long the doctor was in the first room. And when it ran excessive, she would kind of put her ear to the door and see if it was clinical stuff or social chatter. If it was social chatter, what she would do is she would just knock on the door and say, doctor, your patient next door is ready for you now. And that was a signal that the doctor understood meant that he has to move on. And if by chance the doctor still has some important clinical things to talk to the patient about, all the doctor has to say to that scribe is, would you let that patient know I'm going to be in here a few more minutes? And that way the doctor can make a decision. Yes, I need to cut this short, or no, I need more time with this patient. And the patient has no idea what that communication meant. And it worked really well in my practice. All right. So thank you for joining me today. Our next webinar is going to be Thursday, September 5th at 2 p.m. We're going to be talking about going undercover and leveraging secret shoppers to boost your medical practice's performance. You can also use secret shoppers to assess things like compliance, whether your staff are doing what they're supposed to do as far as hand washing and disinfecting equipment and things like that. And also we can secret shop your competitors and tell you what they charge for, lens implants or whatever it is you want to know. We can give you insight to that. So that's a really valuable exercise. Thanks so much for watching today. If you want to contact me, my contact information is here. And again, thank you for watching and hope you have a great rest of your day.